The impact of opioid and benzodiazepine analgesics on delirium in ICU patients. Delirium is a preventable and reversible condition causing cognitive impairment, inattention, disturbance in consciousness, psychotic features, memory loss, confusion, and emotional disturbance. This topic is significant to nursing practice because ICU delirium is most prevalent in the elderly population, and in adult ICUs, that is the most commonly seen population. Research states that delirium is associated with increased rate of mortality in 30 days and 30 days post-discharge. It is associated with longer length of stay, restraint use, rehabilitation, and increased hospital costs. The implementation of delirium risk modification projects such as CAM ICU should be utilized by staff nurses. Utilization of benzodiazepines and opioids are usually the culprits of developing delirium, and they are commonly used in the ICU. Developing high-risk medication delirium is very common, and nurses should be able to identify risk factors and signs for delirium. The purpose of this study. Occurrence of delirium is common, usually left undiagnosed and untreated. It is mistaken for other psychological illnesses. High-risk medications commonly used in ICU settings are usually the culprit of developing and maintaining delirium. With more research, we can see how medications increase the risk for delirium, which medications increase the risk for delirium, and critical timeframes for the use of medications and procedures. My research question is, in ICU patients, do the use of benzodiazepine or opioid analgesics increase the risk for delirium when compared with those who did not receive these analgesics in a 3-month period? Methodology. So conducting some research, I found a couple of studies that are able to be applied to this question. Dupre has a study named Opioid Use Increases the Risk of Delirium in Critically Ill Adults Independently of Pain. This study evaluated the association between opioid exposure in ICU and the occurrence of delirium. It is a quality improvement project to reduce the use of high-risk medications and length of stay by increasing staff nursing education and CAM ICU assessments. Basically, he had the staff nurses implement CAM ICU and CPOT utilization like twice daily in their assessments of patients. Bury pharmacological and non-pharmacological interventions to prevent delirium in critically ill patients, a systematic review and network meta-analysis. This study compared the effects of prevention interventions on delirium occurrences in critically ill adults. They used randomized and quasi-randomized controlled trials examining non-pharmacological, pharmacologic, or multi-component preventions of delirium. Kotfis, Mara, and Wesley, ICU Delirium, a diagnostic and therapeutic challenge in the intensive care unit. It was a qualitative approach and presents risk factors, monitoring tools, prevention options, and treatment options to improve patient care. Lastly, Bastos, the prevalence of delirium in intensive care patients in association with acetoanalgesia, severity, and mortality. Establishes the prevalence of delirium and associates it with the use of sedatives and analgesia and aims to explain the severity and mortality of its effects. So for the settings and samples for these studies, Dupre provided education on staff nurses of an ICU regarding high-risk medication use and the assessment of delirium using CAM ICU. They studied 4,075 adults admitted to the ICU with a total of 26,250 ICU admission days. Bury also was in an ICU setting and studied 11,993 patients. Kotfis just had a questionnaire to staff nurses in an ICU, since this was a qualitative study. And Bastos visited two intensive care units with critically ill adults, 157 patients, utilizing RASS score screenings for sedation levels and the delirium screening checklist for assessment of delirium each shift. They then took their results and used t-test and chi-square analysis. So the results. For Dupre, he found that opioid administration in ICU increases the risk of developing delirium based on dosages. Bury found that benzodiazepines versus a placebo caused more delirium, and that Precedex, dexmedetomidine, reduces the occurrence of delirium, and that sedation medication such as propofol reduces the occurrence of delirium as well. Kotfis found that ICU nurses should be implementing the ABCDEF care bundle, or CAM ICU, to prevent and manage delirium, and I have examples of those on the next couple of slides. Bastos found that the use of sedatives and analgesia were associated with the presence of delirium, but unfortunately was able to determine a time frame. The ABCDEF model. A stands for assess and prevent managing pain, so using the CPOT score in your ventilated patients and treating pain as necessary. B stands for SAT and SBT regarding to your mechanically ventilated patients. C is choice of sedation, so whether it be these high-risk medications, avoiding benzodiazepines if necessary, implementing propofol or Precedex, or even non-pharmacological interventions. D stands for delirium monitoring and management, so utilizing that CAM ICU assessment, again, non-pharmacological interventions, sleep bundles, and treating hyperactive behaviors. E stands for early mobility and exercise, so early progressive mobility, turning patients if possible, getting them out of bed. And F stands for family engagement and empowerment, just advocating for your patient and collaborating with family and physicians on the best route of care. CAM ICU model is an assessment model that's usually utilized every shift for ICU nurses in their charting. It assesses acute changes from baseline mentation. It determines if the patient has inattention, so if they can't pay attention to what you're saying and, pay attention to one task at a time. 3 is altered level of consciousness, so determining GCS and utilizing RAS scores. And then 4 is disorganized thinking, not being able to complete tasks. So with my review of the literature, many studies show relation between opioid and benzodiazepine analgesics on the effect of delirium in the ICU. The implementation of education to staff nurses regarding early detection and prevention is essential. CAM ICU and that ABCDEF model can benefit. Difficult to pinpoint time frame for developing delirium. Implementing sedation vacations, early breathing trials, and the use of propofol and Precedex. There is no definitive answer to if opioids or benzodiazepine analgesics cause ICU delirium. They definitely have an effect, but there is no definitive answer. And there's my references. Thank you.